this, we have an overlap between your wrist and the hand, so some of these things will kind of fit either leg. So starting first with your carpal bones. The biggest thing for this is to make sure whatever mnemonic you use, you know what direction you're going in, okay? That's where people get tripped up the most. So if you look at this top one, straight line to pinky, here comes the thumb. We're going this way. Straight line to pinky, here comes the thumb, okay? Versus some lovers try positions that they can't handle. You're going this way and then coming back and starting the second line that way. So again, just make sure whatever you're using, you know what line and what order you're actually going in so you don't get confused. Okay? That makes sense? Okay. But for this, make sure you know the names of the carpal bones, where they sit, and then we will practice palpating each one of them individually in lab. Okay? That will also help with your orientation a little bit as well. Okay, so we're going to start first with the radiocarpal joint. Okay? So this is going to be the articulation between the distal end of the radius and the radial ulnar disc with the scaphoid, the lunate, and the triquetrum. Okay? So all of those bones are involved in this articulation. Okay? So since we have an articular disc, there's one that sits between the ulna and the proximal row of the carpals. So that is not actually considered a part of the wrist joint. So your radiocarpal joint, this is a synovial joint. It is a biaxial condyloid joint. So that means it allows for wrist flexion, extension, ulnar deviation, and radial deviation. Okay, so we have movement in two planes around two axes. Okay, so if we have flexion and extension at the wrist, what plane and what axis is that? Sagittal plane, frontal axis. Okay, what about radial deviation, ulnar deviation? Frontal plane, sagittal axis. Nice job. Okay, in terms of end fields, I have this, I think, no, not in the next slide, never mind. In terms of your end fields, we have for radial deviation, okay, radial deviation going toward the thumb side. That is a hard end field, okay? Hard end field for radial deviation, okay? Because you have the contact between the styloid, the radial styloid process, and the scaphoid. So that is what restricts your movement going into radial deviation. Okay? All other motions at the wrist are all firm end fields. So radial deviation is your outlier. Okay? In terms of arthrokinematics at the wrist, okay? In open chain, this is going to be a convex on concave articulation. Okay, your carpal bones are going to be convex. So that means that they would move the opposite direction as the hand motion.
Open change, convex.
Sorry?
Open change.
Open chain, convex on concave. Carpal bones convex. Okay, so I'm going to list these out exactly. So write these down. Okay? For wrist flexion, your carpals will glide posteriorly and roll anteriorly on the radius. For wrist flexion, your carpals will glide posteriorly and roll anteriorly on the radius. For wrist extension, the carpals will glide anteriorly and roll posteriorly. For radial deviation, the carpals will glide medially and roll laterally. For radial deviation, the carpals will glide medially and roll laterally. And then for ulnar deviation, the carpals will glide laterally and roll medially. Okay, so here's your joint position information for your radiocarpal joint. Okay, so your open pack position is going to be in neutral with very slight ulnar deviation. The closed pack position is going to be in wrist extension and radial deviation. And then your capsular pattern, flexion is going to be equal to extension in terms of joint limitation. Okay, here are your range of motion norms at the bottom. So wrist flexion, you want 80 degrees, wrist extension, 70 degrees, ulnar deviation, 30 degrees, and radial deviation, 20 degrees. Okay, all of that is just going to be straight memorization. Okay, we also have the mid-carpal joint. So this is basically this line right here between the two rows of the carpal bones. Okay, you also have intercarpal, which are actually these lines between each individual carpal bone. Okay, you'll hear these also used interchangeably. These are all considered non-axial gliding joints. Okay, so you're not going to have a roll associated with them. There's not very significant movement between them. You're just going to have a slight gliding motion. Okay, all of these bones are irregular in shape. Okay, so in terms of your actual classification, they're going to be non-axial gliding joints or non-axial plane joints. Okay, carpometacarpal is on this side. So this is going to be this pink line between your distal row of carpal bones and your metacarpals. Okay, so I want you guys to pause, fix your drawings just based on that information. So again, labeling your carpal. So we're going to move into the ligaments now. Okay, so you have 4 major ligaments that support the wrist. Okay, the first one listed up here, you can see the red circle, is called the radial-collateral ligament. Okay, this is going to attach to the styloid process of the radius and then to the scaphoid and the triquetrum. Okay, so same goes for before. Make sure for the ligaments you know where they're at, you know what they attach to, and you know what motion they are restricting. Okay, so for this one, this is going to provide lateral support for the wrist because it's sitting on the lateral side. Okay, so its job is going to be to prevent excessive ulnar deviation. Okay, preventing excessive varus stress because of its location. Okay, so again, radial-collateral ligament, it sits between the styloid process of the radius and the scaphoid and trapezium. It provides lateral support to the wrist and prevents excessive ulnar deviation. Okay, on the other side, we have the ulnar collateral ligament. Okay, so this is sitting on the ulnar side. Again, this is going to attach to the styloid process, but of the ulna. Okay, and then it's going to run up to the triquetrum and the pisiform. Okay, so it's exact opposite here. So this is now providing support to the medial aspect of the wrist, and it is preventing excessive radial deviation.
Where do I attach to it here?
So it's going to attach to the styloid process of the ulna, and it's going to go to the pisiform and the triquetrum. It prevents excessive radial deviation. Okay, we also have the palmar radiocarpal ligament. this is going to attach from the anterior surface of the distal radius and the ulna to the anterior surface of the proximal carpal bones, and then just to the capitate of the distal row. Okay, so again, anterior surface of the distal radius and ulna to the proximal row of carpals plus the capitate in the distal row. Okay. Since this ligament is on the palmar surface, this is going to limit wrist extension. Okay, and this is important because most activities are going to take place with the wrist in extension. Okay, so this ligament has to be very strong. Okay, a lot of Fuchs injuries will damage this ligament because that's going to be a forced extension of the wrist. Okay, so then in opposition to this, on your other side, you have the dorsal radiocarpal ligament. Okay, so this is now attaching from the posterior surface of the distal radius to the posterior surface of the scaphoid, lunate, and triquetrum. Okay, so this is going to be the exact opposite. All right, so this is going to become taut in wrist flexion. Okay, so it's going to limit excessive wrist flexion. Okay, since you don't have as many activities that are taking place in wrist extension, this one is typically weaker in comparison. Okay, so those are your four big ligaments. There is also an articular disc, like we mentioned earlier. Okay, this sits at the distal end of the ulna, and it articulates with the triquetrum and the lunate. Okay, this is going to act as a shock absorber. Okay, it also is used as a filler. So if you look at this space, you can see how these bones aren't going to articulate perfectly. So this kind of helps to fill this space in between your proximal row of carpals and your ulna.
Does it extend also to the distal end of the radius, or it's just the ulna?
No, it's just the ulna. Okay. We also have what's called the palmar fascia. Okay. This is going to be just a really thick triangular fascia that sits right in the palm. So it's this triangular-like structure right here. Okay. This is going to cover a lot of the hand muscles and the extrinsic muscles that go into the hand. So it'll help to provide a little bit of protection for all of those structures. And then it also serves as a muscular attachment for your palmaris longus muscle. Okay, and that will, run down the forearm and then kind of blend right into this fashion. Okay. All right, so now on your boards, yeah.
And it's superficial, so it's above all
Yes.
the ligaments that we just
Yes.
discussed? And then there's muscles on top of it, or no?
It sits on top of the muscles.
It sits on top.
Because it protects them. All right, so now you are going to fill in your ligaments that we just discussed. Everything else we talked about, we're not going to go in detail in class to your origins, insertions, actions, and nerves, but you are responsible for all of that material for each of these muscles. Okay? So remember, like we talked about last week when we were going through the elbow section, a lot of these forearm muscles have a common origin, okay, at the elbow. So for the medial epicondyle, you have your common flexor tendon. So a lot of those muscles that flex the wrist are all going to originate at the medial epicondyle, okay? Versus your wrist extensors are going to be at the common tendon at the lateral epicondyle, okay? Any questions on that? Okay. All right, so for your wrist flexors, okay, you have your flexor carpi radialis, flexor carpi ulnaris, and your palmaris longus. Okay, the palmaris longus, that is actually not present in all people. Okay, so that's one of those muscles that doesn't have a ton of functional significance. So if you look at your wrist, if you flex your wrist, it would be the one that is right in the very center of your wrist if you have it. Okay. So if it is absent, there's no real change in your ability to function. Okay. We also have your flexor digitorum superficialis, flexor digitorum profundus. Okay. So for these ones, your flexor digitorum profundus is going to sit deep in relation to the flexor digitorum superficialis. Okay? An important thing to note about these ones, if you go, I don't know if you can see if you look up here, but if you look on your screens, you can see for flexor digitorum superficialis, how as it gets to its distal attachment, the tendon splits into two different pieces and then inserts on the medial and lateral aspect of the phalange. Okay? And then your profundus runs through that split, and it has a straight line down all the way to the distal phalange at each digit. Okay? So that profundus is going to run through the split of superficialis. Okay, so just make sure you understand that conceptually. Okay? So since profundus runs all the way to the distal phalanges, that is the only one that flexes the DIP. Okay, so it's the only attachment that goes down that far. Okay, wrist extensors, extensor carpi radialis longus, extensor carpi radialis brevis, extensor carpi ulnaris, and then we also have extensor digitorum, extensor pollicis longus. All right, ulnar deviation, radial deviation, these ones are easy to remember because of their actual names. Okay, so for ulnar deviation, that is going to be a combination of your flexor carpi ulnaris and the extensor carpi ulnaris. So they have those words ulnaris in them, so you can remember that those are the ones that ulnarly deviate. Okay, same thing for radial deviation. Extensor carpi radialis longus, extensor carpi radialis brevis. They both have radialis in the name. They are going to radially deviate. Okay? And then, of course, we have the nerve supply. So I think in the hand lecture, we go a little bit deeper into the nerves, so hold tight here. But for this, again, make sure you know your nerves for your motor distribution, but also for your sensory distribution. Okay? A lot of these types of diagrams are color-coded, so you can really see where that sensory distribution is for the different nerves. Okay. And then just a couple things for pathology. Again, a lot of the pathology we'll dive deeper into once you guys get into orthopedics, but just some to kind of dip your toes in a little bit. This right here, Colles fracture versus Smith's fracture. This is often a board question. Okay, in some way, shape, or form. So make sure you understand the differences between these two. Okay, in a Colles fracture, the distal end of the radius will displace posteriorly. Okay, and then in a Smith's fracture, the distal end of the radius displaces anteriorly. So that is the big difference between what is actually occurring with these types of fractures. Okay, these will both occur typically with a fall on the hand, okay? The Colles fracture is usually going to be a fall on a wrist that is extended versus the Smith's fracture is going to be a fall on a flexed wrist. Okay, so that one's real important. Scaphoid fractures, okay? Again, this is often going to occur with a fall. So fall on an outstretched hand where you land right on the scaphoid fractures. Okay? Again, very common board question. Okay? What is important about this type of fracture is that it is very susceptible to avascular necrosis. Okay? The scaphoid does not get good blood supply. So with this type of fracture, it can end up leading to avascular necrosis, death of the bone tissue, it can be really severe. Okay, we also have a ganglion cyst. This is basically just a fluid-filled sac that occurs on the dorsal surface of the wrist. They can appear, they can disappear, they can change in size very quickly. You don't typically see these very often in clinic, and if you do, it's not typically what you're actually treating. And the biggest thing I would say about this is a lot of people, for some reason, will try to hit them with a book as a very common thing that you will hear. I don't know why. If you have a patient with them, I would just advise against that. So, that's it for that one.
Where did that come from?
I don't know, it's, I think like an old, I don't know. Yeah, it was a book. I've heard that so many times, I can't even tell you. It absorbs right back in when you do that. All right, and then wrist sprains. Okay, again, all of these wrist injuries are gonna occur with a fall on an outstretched hand. When that happens, you're typically going to go into wrist hyperextension, so you're gonna sprain your ligaments. With that, the most commonly sprained ligament is actually the scapholimby ligament. Okay, so the ligament, it just literally sits right between the scaphoid and the ligament. Okay, and that is it for the wrist. So if you guys wanna take, a quick little break, go to the bathroom, get a snack, and then we'll continue on with the hand. No overlap here, and that's okay. But we're gonna start just first with the joints of the hand, okay? So, making sure you understand the name of the joints, where exactly they sit when you're looking at all of your hand bones, okay? And then also not only knowing the full name, but also the acronym that you're gonna mostly see it written as, okay? So right here, you have your carpometacarpal joints. This is gonna be the articulation between your distal row of carpals and your metacarpals, okay? Carpometacarpal joints. Going up one more, you have your metacarpophalangeal joints. This is gonna be the articulation between your metacarpals and your proximal phalanges, okay? At the thumb, we know we don't have as many thumb bones as we do in digits 2 through 4, okay? So this one is just gonna have an IP joint, okay, interphalangeal. Versus digits 2 through 4, you have your PIP and your DIP. So proximal interphalangeal joints and distal interphalangeal joints, okay? So make sure you have these labeled properly on your drawings and you understand the differences between them. Okay, so we have a lot of joints here, so we're gonna kind of start at the bottom, work our way up, make sure we feel comfortable with them. Okay, so first we have our carpometacarpal joints. So what is this the articulation between? Say louder. Carpals and metacarpals. Okay, so these joints are going to be different between the thumb and digits 2 through 5. Okay, so it's still all the same joint, it's still the same articulations, but things are gonna look a little bit differently depending on which one that you're looking at. Okay, so again, here's the articulation between our carpal bones and the metacarpals. Okay, these are going to be so 2 through 5 are going to be non-axial, plain synovial joints. Okay, so you're going to get a slight gliding motion. But in general, these are going to provide more stability compared to mobility. Okay, versus at the thumb. Okay, this is going to be the articulation between the trapezium with the base of the first metatarsal. Okay, this is classified as a modified biaxial saddle joint. Okay, so that means that both surfaces are both convex and concave.
It's the articulation between the trapezium and what?
And the first metacarpal. Okay. Okay, we'll come back to the thumb in a minute. All right, for our MCP joints. Okay, again, this is going to be your articulation between the metacarpals and the proximal phalanges. Okay, so here, these are basically your knuckles. All okay? Again, articulation between the metacarpals and the proximal phalanges. Okay, so I have written your norms for these different joints here. Okay, not all of the motions have a norm for the hand. Okay, or if they do, your board prep book is not worried about them, so we're not going to worry about them. All right, so at these joints, you have 2 degrees of freedom. They can perform flexion and extension, as well as abduction and adduction. Okay, flexion at digits 2 through 4 is going to be 90 degrees. Extension is going to be 45 degrees. Okay, in terms of abduction and adduction, this is going to occur in reference to your middle finger. Okay, so we're abducting away from the middle finger, we're adducting toward the middle finger. That's your point of reference. Okay, and that's why it makes it a little bit harder to actually measure. At the thumb, this is going to be a uniaxial hinge joint where you're only getting flexion extension. Okay, for your arthrokinematics, your proximal phalange is going to be concave versus the metacarpal heads are going to be convex. And then moving up, we have your interphalangeal joints. Okay, so again, at the thumb, that's all you get. And then at digits 2 through 5, you have your PIP and your BIP joints. Okay, so these are all going to be uniaxial hinge joints. You're only going to get flexion and extension at these joints. Okay. All right, for your thumb, let's see everybody's hands. All right, show me flexion, extension, abduction, adduction, opposition. Good, any questions?
The adduction will be in a frontal plane or more.
Who knows? It's gonna be opposite than your norm. Okay, so abduction, adduction is going to occur in the sagittal axis in a frontal plane.
And flexion
Flexion extension.
as well. Oh,
No. Flexion extension is going to be your frontal, hang on, did I just say that backwards?
Okay.
Frontal plane, sagittal axis. Flexion extension. Right?
Yeah.
Did I say it backwards the first time?
Yes, but that's okay. It's
Okay, take 2, forget everything I just said, because now I don't know what I even said. Okay, flexion extension of the thumb. Okay, this is going to occur in a frontal plane, sagittal axis.
that's good.
And then abduction, adduction occurs in the sagittal plane, frontal axis. So it is opposite than your norm. Go with that? Did I just confuse everybody? One more time.
Now it's good.
One more time. Flexion extension of the thumb occurs in the frontal plane, sagittal axis. Abduction, adduction of the thumb is going to occur in the sagittal plane, frontal axis. So it is opposite than your normal movements.
I think it makes sense if you put your arms down
In anatomical position. Everybody go with that? Okay. So then here are all of your norms specific for the thumb. Okay. If you have a hard time understanding how something can be both concave and convex, think about the Pringle chip. Okay. It's a really good analogy for being able to see how something can be shaped with both a convex and a concave surface. Okay, so that is what the joint looks like for the thumb. All right, moving on to your hand ligaments. Okay, the hand has a gazillion different ligaments, so we are not going to go through every single one. Okay, so just take note kind of what we talked through. Make sure you know where those sit. Okay, So starting first with your flexor retinaculum, okay? This is going to be a band just of connective tissue that spans the anterior surface of the wrist, just in a horizontal direction, okay? So you have this whole band right here, just sits horizontally, okay? So this is going to attach to the radial styloid process and the ulna and cross over your flexor tendons, okay? So you can see right here, it's pretty superficial and everything's gonna run underneath it, okay? So its primary job is to hold the flexor tendons in place. Okay. With that, it will also assist in preventing any type of movement of the radius and ulna. So it also holds those together as well. Okay, so you have two separate parts to the flexor retinaculum. You have the palmar carpal ligament and the transverse carpal ligament. The palmar carpal ligament is going to be more proximal and more superficial in comparison. Okay, versus your transverse carpal ligament is going to be a little bit deeper and more distal. Okay. The palmar carpal ligament, in terms of its actual attachments, is going to attach to the styloid process of the radius and ulna, cross over your flexor tendons, just like we said at the beginning. Okay? Versus your transverse carpal ligament, with it being a little bit deeper, it's going to attach to the pisiform, okay? As well as the hook of the hammock, so you can see it a little bit better in this image here. Okay? And then it's gonna cross over and attach to the scaphoid and the trapezium. Okay, so again, transverse carpal ligaments, that is going to attach from the pisiform and the hook of the hammock, cross over and attach to the scaphoid and the trapezium. Okay, so this portion of the ligament is what is really implicated in carpal tunnel syndrome. Okay, because it is forming this roof right over the carpal tunnel.
The transverse.
Transverse. Okay, so underneath that ligament, you have your flexor tendons and your median nerve that travel right underneath it. So it's very easy for those structures to get compressed in that tiny little space. Okay, so if they were to do a carpal tunnel release, I'm sure you've heard of that. This is the ligament, they go in and they cut it to give more space to those underlying structures. All right, on the opposite side, similar structure, we have the extensor retinaculum, okay? So again, this is just gonna be a fibrous band that sits on the dorsal surface of the wrist. Its job is to protect and stabilize the extensor tendons that cross the wrist joint, okay? So again, you just have this horizontal structure, all of your tendons run underneath it, okay? This does not typically cause problems, okay, unlike the other side. You don't see a lot of this. The only thing that you might see, again, is that ganglion cyst. All right, you also have what is called the extensor expansion or the extensor hood. Okay, so again, this is more just fibrous tissue that is running over top of the digits. Okay, so this is attaching and running again on the dorsum side of the digits, and it's attaching to either side. Okay, most specifically on the proximal ligament. Okay, it's going to cover the entirety of the metacarpals and then maintain the extensor tendon in the groin. Okay, so that's its job. It protects the extensor tendon and keeps it running right along the top of the finger. Okay. On each side of the joints, you have your collateral ligaments. Okay, so at your PIP joints, your DIP joints, and your IP joint. Okay, this is going to help to reinforce the capsule and prevent any type of finger deformities. Okay, so you have a medial collateral ligament and a lateral collateral. okay, or ulnar and radial terminology would be interchangeable. Okay, so again, just runs on either side of the joint, helps to prevent finger deformities. Okay, and we're gonna talk through just a couple of them toward the end of this lecture. Okay, but if they're ruptured, then your finger strength, the dexterity of your fingers is going to be impaired. Okay, and then last one here is your finger tenosynovium. So again, this is going to be more a fibrous sleeve, and it actually surrounds the tendons of the hand. Okay, this is important because it is really easy for this structure to get inflamed and swollen, scarred down, and it is often implicated in what is called a trigger finger. Okay, so when part of this structure kind of gets bundled up, again, it stops moving like it's supposed to, then you end up with almost what feels like a little nodule, kind of at the base of your fingers, and the finger will get stuck in flexion. Okay, so that's why it's called a trigger finger. You know, if you're doing that repetitively, it gets stuck in that position, and then you would have to kind of passively release it in order to extend the hand. There could be an audible snap with that as well. So that's the big, direction that you guys want to take this long term, so that's why it's important to know this structure. Okay, with that, the middle finger and the ring finger are going to be the most common digits that you'll see this occur. All right, hand muscles. Okay, so first, as we're starting to get into the hand muscles, we need to understand the differences between intrinsic and extrinsic muscles. So somebody tell me what those are. Correct. Okay, so intrinsic versus extrinsic. Your extrinsic muscles will originate on the forearm and insert in the hand, versus your intrinsic muscles are going to both originate and insert in the hand, so they are not going to cross the wrist joint. Okay, same concept for the feet once we get to the feet. Okay. All right, so a lot of the muscles that you guys are going to learn from the wrist section, all of your forearm muscles, a lot of those actually insert in the hand. So understanding that those are more your extrinsic muscles versus a lot of the ones from this lecture are going to be more your intrinsics. Okay? All right, so starting first with your finger flexors. Okay, again, these are going to be repeat from the last slide deck. So these are your extrinsic finger flexors. So you have your flexor digitorum superficialis, flexor digitorum profundus, and flexor pollicis longus. That's specific to the thumb. Anything that says pollicis is just the thumb. Okay? What did I say in the last lecture about superficialis versus profundus? Exactly. So how does that affect the actions? Say it loud. Correct. Okay, so remember, superficialis has the tendon that splits, inserts on either side of the proximal phalange, and the profundus has one straight tendon that's going to run through that split, insert at the distal phalange, so it's the only one that can flex the distal portion. Okay. I have the innervations listed on these ones as well, so you guys can work on learning those. Then we have your intrinsic finger flexors. Okay, so the deepest muscle groups of the hand are going to include the interossei and the lumbricals. Okay, so for these ones, you do need to know the origins, insertions, actions, and nerves. Okay, these are things that we didn't cover in Bio 150, so make sure you add those ones in and you know those as well. Okay. Pad and dab, have you guys ever heard of that? Okay, that is a really easy way to remember the actions for your interossei. Okay, you have palmar and dorsal interossei. Okay, so palmar are going to adduct, pad. Palmar, adduct. Dorsal interossei are going to abduct. Okay, dab, dorsal, abduct. Okay? Alright, and you can see in these pictures kind of where they're all sitting. Okay? Alright, so then for the thumb, you'll hear this also called the thenar eminence. Okay? So thenar is going to be the thumb side. Hypothenar is going to be the pinky side. Okay, so thenar eminence and hypothenar eminence. Your thenar muscles, again, thumb side, those are listed here. Anything that says pollicis includes the thumb. Okay, so you have your abductor pollicis brevis, flexor pollicis brevis, adductor pollicis, and opponens pollicis. Okay, it's easy to remember their actions because the actions are all in the name. Okay. Same thing there, make sure you understand where these attach, origins, insertions, actions, and nerves. Okay? These are all going to be innervated by the median nerve, except for the adductor pollicis, which is the ulnar nerve. Okay? Pinky side, what are those called? Hypothenar eminence. Okay, so again, we are now on the pinky side of the palm. Okay? For these, anything that says digiti minimi is in reference to the pinky. Okay? So you have your abductor, flexor, and opponens. All of these are going to be innervated by the ulnar nerve. Okay? All on the ulnar side, that one's easy to remember. Okay? Moving towards your extensors. So extrinsic finger extensors, we already went through extensor digitorum. Extensor digiti minimi, again, that's going to be referenced to the pinky, but it is technically an extrinsic muscle. And then extensor indices. So that one is just responsible for extending your index finger. Okay? So again, if you know the names, it's easy to figure out those actions. Okay? These, since we're on the dorsal side, these are all going to be innervated by the radial nerve. Okay? Extrinsic thumb muscles. Okay? Again, anything that says pollicis. Okay? Flexor, adductor, extensor pollicis longus, extensor pollicis brevis. Everything here is going to be innervated by the radial nerve, except for the flexor pollicis longus, which is the median nerve. Okay? We also have what is called the anatomical snuff box. Okay? So if you take your hand, you kind of spread it out, you can see these tendons that form right at your thumb. Okay? So see if you can do that and see that little triangle. Okay? This is going to be made up, let's see, I don't know if it's listed, I think you can see it, of extensor pollicis longus, that's this one right here, extensor pollicis longus, extensor pollicis brevis, right here, and abductor pollicis longus. Okay? That is this one right here. So these three tendons make up that snuff box. Okay, those are the borders of that indention. Okay, so in order to remember it, a common thing that people will use is that it makes a brevis sandwich. Okay, extensor pollicis longus, extensor pollicis brevis, abductor pollicis longus, brevis sandwich. Okay, so again, here's another picture of it and what it looks like on a regular hand. All right, moving on to your nerves. Okay, so I have it, broken up into the different nerves, their innervations, and what would happen if one of these nerves was compressed or damaged in some way. Okay, so now at this point, we talked about your brachial plexus, the shoulder, the elbow innervations. Now we're adding wrist and hand. So all of these peripheral nerves, the peripheral nerves don't change, but we're just adding on muscles. So make sure you're able to group all of them together. For each nerve, I should be able to give you a nerve, and you list out all of the muscles that it innervates. Okay? So you have to be able to approach it from different ways. If you get a muscle, tell me the nerve. If you get a nerve, tell me the muscles. Okay? If you get a pathology, what nerve is involved? If you get a pathology, what muscles are going to be impaired because the nerve is involved? Okay, so start looking at it from all different angles. Okay, so for these, I tried to list out a lot of the ones from this section. This is not all inclusive, but if you look at these pictures, they have all of the innervations for these particular nerves listed. Okay, so for your radial nerve, for example, from this section, we have extensor carpi radialis longus and brevis, extensor carpi ulnaris, extensor pollicis longus and brevis, and abductor pollicis longus. Okay, so we know this is going to be more on the dorsal side of the forearm, and all of these muscles are going to be involved in what action? Wrist extension. Okay, so we know if the radial nerve is damaged somewhere, that wrist extension is going to be one of our primary actions that is impaired or they're unable to perform. Okay, so if there was nerve damage, what you would see is a wrist drop. Okay, so that would be the deformity that somebody would present with. Let's say if the radial nerve was severed up at the humerus. Okay, so none of these muscles get innervation from the radial nerve. The person is unable to actively extend their wrist. So they're going to present with a wrist drop. Okay, so wrist drop paralysis, weak wrist extension, they might have difficulty holding objects in hand due to the limited tenodesis. Do you guys know what that is? So basically, if you were to drop your wrist, your fingers are naturally going to go into flexion. You extend your wrist, they're naturally going to go into finger extension. Okay? This can be used, this is just because of our natural anatomy, without any muscle activation. So if you had a patient who was a spinal cord injury, depending on the level, if they had wrist flexion extension, they could still grasp objects even if they didn't have any innervation into their hands. Does that make sense? So it's just a way to grasp things. But that's what that's talking about.
And that's called tenodesis?
Tenodesis. Okay, for the median nerve. Okay, so same thing here. So you have innervation for all of these muscles here. You have your picture of your nerve and all the muscles that it innervates. And then nerve damage here. This is going to be called an 8-hand deformity. Okay, so you can see in this picture, you have a flexion of the index and the middle fingers. Okay, that's your 8-hand. They're also going to have weak wrist flexion. Their thumb muscles are going to be weakened, and then a weak grasp as well. For the ulnar nerve, same thing. So here are all your muscles that are innervated by the ulnar nerve. Your deformity here is going to be a claw hand. So with that, the pinky and the ring finger will be flexed. Yeah.
Is this also called poke hand as well?
Is it called what?
Poke hand?
Yes. Okay, so here, weak ulnar deviation, weak 4th and 5th digits, and then a weak pinch. And we're going to go through the different types of pinches in just a minute. Okay? And then again, so coming back to sensation always, make sure, especially in the hand, you know what part of the hand gets sensory distribution from the ulnar nerve, from your radial nerve, and from the median nerve. Okay, so ulnar nerve is going to get the pinky side of the hand and half of the ring finger. Okay, median nerve is going to get everything else when you're looking at the palmar side. Radial nerve is going to come on the dorsal side of the thumb, and it's again going to get most of the dorsum of the hand. Ulnar nerve is going to get that pinky side and half of the ring finger, and then median nerve is going to get the digits at the top. Okay. All right, moving into your different types of grasps, and then a little bit on pathology. Okay, so this right here is important because this is the functional position of the hand. Okay, so basically all that means is that if there was a patient who had some type of hand or wrist injury, this is likely the position that they're going to be splinted in. Okay, it's gonna be the most common splint position. It is the most functional position of the hand. So slight wrist extension, you can see that here, it's very slight. But this is going to be, the position that they use. MCP flexion, PIP flexion, and very slight thumb position. Okay, into your different types of grip, okay? So, the ability of the hand to grasp is, you know, what our hands are for, right? This is also called prehension. So that is the actual term that is used for grasp, prehension. Okay, basically the ability to hold or manipulate objects. Okay, we have two major categories for prehension. They include power grips and precision grips. Okay, so a power grip, that's what we're gonna go through first. This is basically any type of motion where you're holding an object, well, forcefully I think is technically in the definition, but where the hand is not actually what is doing the work. So if you think about something where you're holding the hammer, yes, you're grasping it with your hand, but the actual movement is coming from more proximal. Okay? Versus your precision grips are going to be very fine motions at the fingers directly at the hand. Okay, so we have three big types of power grips. We have the cylindrical grip, the spherical grip, and the hook grip. Okay? The cylindrical grip, all of the fingers are going to be flexed around the object, and the thumb is going to be wrapped around in the opposite direction. Okay? So you can see in the picture, oftentimes the thumb is going to be wrapped around in the opposite direction, but it's also going to overlap the fingers in that type of grip. Okay, so a cylindrical grip. The second one is the spherical grip. So here, the fingers and the thumb are going to be abducted as it wraps around an object. So if you think about something like holding on to a doorknob or eating an apple, something like that would be your spherical grip. A baseball, okay? Versus your hook grip, that is where your second through fifth digits are wrapped around an object and your thumb is not really involved. Okay? So if you think about like holding a briefcase, okay? You pick it up second through fifth digits, your thumb is not actively involved in that process. Okay? So those are our big power grips. Versus precision grip. Okay, again, these are going to be fine movements of the fingers. Okay, so think about things like holding a pen, threading a needle. Okay, very tiny movements. Okay, so we have four common types. We have pad to pad, tip to tip, pad to side, and side to side. Okay, so for your pad to pad grip, okay, there are a couple different variations for this one. First, you have a pinch grip. So for a pinch grip, that is going to be when it involves the pads of the index finger and the thumb. Okay? Pinch grip. We also have a tripod grasp. That's going to involve two fingers and the thumb. Okay? Tripod, there's another name for it. It's kind of weird, but it is called the three-jaw chuck. Okay, write that down. Three-jaw chuck. Okay? But again, pad to pad, so you're actually on the pads of the fingers. Okay? Next we have tip to tip. This is also called the pincer grip. Okay, and it is exactly what it sounds like. Tip of the finger to tip of the thumb. Okay, tip to tip. Pad to side, this is also called lateral prehension. Okay, that's going to be the pad of the thumb to the side of the index finger. Okay, so again, common one there is holding the key like in the picture. Pad of the thumb to the side of the index finger. Okay, and then side to side, this is just going to be adduction of the index and middle fingers together. So something if you're like smoking a cigarette, okay, and holding it between those two digits. Okay, side to side. Okay, last type of grip that we have is called the lumbrical grip. Okay, this one is really important because it is the type of grip that you should use when handling patients. Okay, so with this, basically you have flexion of your MCP joints and extension of your PIP and BIP joints. So that's what it should look like. Okay, lumbrical grip can do the same thing if you were holding a plate.
Can you say that again?
Flexion of the MCP joints, extension of the PIP and BIP joints. Okay, whenever you guys are handling patients, you want flat fingers. You never want to be digging your fingers. You don't want to be flexing and grabbing onto them in that manner. Okay, so always a lumbrical grip. Okay, let's pause for a second, get with a partner, and go through the different types of grips. Here, just introducing some of the concepts. So we already mentioned carpal tunnel earlier. So again, we know this is going to be a really common condition. You're going to see a lot of it. And it is going to involve compression of the median nerve as it goes through the carpal tunnel. Okay? So if there is overuse of the surrounding tendons, any type of damage to those, they are going to swell in that space. If the tendons get inflamed, then they're going to need to take up more space, and oftentimes the median nerve is what gets compressed. Okay? So with that, they are likely going to present with some numbness and tingling in the hand in the median nerve distribution because that's the nerve that is compressed. Okay? So this is why it's important for you guys to know your dermatomes and your sensory cutaneous innervation for these nerves. Okay? So when someone comes in and all the information that you get is, oh, I have numbness right here, you need to be able to reason through what could be causing that so you know how to treat it. Yep.
So, I know it's usually caused
You're gonna
by
speak up a little bit,
I
Garth.
know the carpal tunnel syndrome is usually caused by repetitive motion, repetitive movement. But is it like the bones themselves are tightening the ligament over the nerve?
No, it's so overuse of those muscles, if they become extra hypertrophy, if you get a tendinitis of those muscles, of the flexor muscles, where those tendons are now inflamed and aggravated, they are taking up more space within the carpal tunnel, so there is less ability for the median nerve to move, and the median nerve gets compressed between those different tendons.
So it's just like a general buildup of pressure in the
Yes.
area.
Yep, exactly. Okay, so that median nerve gets compressed and you lose this sensor distribution into the hand. Okay, so again, this is the area that's likely going to be affected in terms of sensation. And then any nerve that is innervated by the median nerve in the hand will weaken. Okay, so especially when it comes to your thumb, your index finger, and your middle finger, those are going to be the digits that are mostly affected when it comes to strength. Okay? In order to elicit symptoms, we'll learn special tests later, but even just tapping right over top of the carpal tunnel, then that can also elicit symptoms into the hand. So it's a really quick, easy way to assess for that pathology.
Would that be like nerve impulses?
Yes.
Okay.
Yep, exactly. You'll also have atrophy of the thenar eminence. So you can't really see it great in this picture, but you can see this one is normal, where there's a lot of muscle bulk. And then on the thumb side in this image, you don't have that muscle bulk. So that's going to occur over time. As the muscles are losing this innervation, you're going to start to see that atrophy as well. Okay? And then like we talked about with the transverse carpal ligament, if they have to undergo surgery, that's what they're going to cut. So you give these tendons in the nerve more space. Okay.
You're losing stability.
To some extent, because we know that that ligament works to hold the radius and ulna together, but that's not usually a functional problem. Okay, we also have a tenosynovitis. This is basically just going to be an inflammation or thickening of the sheath that sits around the tendon. So all of your tendons are going to have this sheath. So this would, be more an individual tendon situation versus something that you're just going to identify in the hand as a whole. So usually it's going to happen in association with some type of tendonitis, tendinopathy. And you can see in this picture here, this would just be your tendon. The sheath surrounding the tendon is what gets inflamed or what gets aggravated. Okay. We also have more specifically de Quervain's tenosynovitis. It's a very common pathology that you guys will see. And it is specifically an irritation of the sheath that surrounds extensor pollicis brevis and adductor pollicis longus. Okay, so this is going to occur on the radial side of the wrist. And in order to assess for this, everybody do it because it can be irritable a lot of times. You're going to put your thumb inside your fingers, extend your elbow, and then you're going to ulnarly deviate. Okay? And if it's present, a lot of times you're going to have symptom recreation right on the dorsum of the thumb. So that can be a little bit uncomfortable. But that's where it's going to occur at. This is very common with new moms. Okay? Something about how you hold baby. I don't know, I haven't been a mom yet. But that is a very common pathology that you'll see in that population.
Is that the one you get from like lifting and bottles and all of that? Because I
Yeah,
had that.
Makes sense. Yep.
I had that when they were little.
I think they said like
Would it
when you're
also-
holding
yeah.
them, like the way that your hand is
I was
turned like
about to
under their
say.
butt or whatever.
That makes sense.
But so if you're
Just a
holding
little
them
bit
like
tension on it.
up under, yeah.
Dupuytren's contracture. So this is going to occur when that palmar aponeurosis, that triangular fibrous tissue that we talked about earlier, where that undergoes nodule thickening. Okay, so it becomes very nodule in nature, and it will start to, because it gets so tight, it will start to make the fingers curl in, okay, into flexion. So oftentimes you're going to see this mostly with the ring finger and the little finger, where they just start to get pulled into flexion because of how tight this structure is. Okay, so those fingers will develop flexion contractures where they are not able to actively or passively move out of that position. Okay. Gamekeeper's thumb. So this is going to be an ulnar collateral ligament injury of the thumb. Okay. Oftentimes this is going to occur in skiing. So you'll also see it called skier's thumb. So when somebody falls and they're holding onto their ski pole, that mechanism of injury right here, where you have this valgus type position, the ulnar collateral ligament is going to tear. Gamekeeper's thumb is more in reference to a chronic UCL injury versus skier's thumb is going to be more an acute injury. Okay, but it is the same ligament that is involved for both of these pathologies. Okay, either way, a lot of times it's going to be involved in a tooth injury. Okay, finger deformities. Again, we'll start with this, but we're not going to dive very deep. And then once we get to orthopedics, we'll go through all of the different types of finger injuries. Okay, so starting first with your swan neck deformity. So this is going to be a flexion of the MCP joint and then hyperextension of the PIP joint and flexion of the DIP joint. Okay, so some people can do this on command. I am not one of those people, so I can't show you, but this is what the finger is going to look like. Okay, so again, MCP flexion, PIP extension, DIP flexion.
It's this one?
Yeah, there we go. There it is.
Beautiful.
Good job.
Do both of them. He says, stop doing that.
Okay, so this, it can be active like that,
I did
but
on this one as
typically
much.
when you have this as a pathology, it's gonna be a fixed deformity, okay? So that occurs due to a full rupture of that terminal extensor tendon. Okay? Versus your boutonniere deformity. This is going to be MCP extension, PIP flexion, and DIP extension. Okay? And this is going to be injury to the central extensor tendon. Okay? So that's what it will look like. Alright? So again, just learn those couple for now, and then we'll learn a lot more later on.
You're strong here.
Alright, do you guys have any questions on wrist or hand?
For the one deformity, which something?
Your terminal extensor tendon. Don't forget to do your chores this week. I know not everybody has been doing them. Please do them. If you have the labs, there is clean laundry in the labs. Please put that away before the beginning of lab. I also got a new thermometer for the hydroculator. So did Dan ever give you guys a sheet for that? Or is that part of
I don't know.
I can't remember. Anyway, somebody's supposed to be checking the temperature, so I have to